Rickettsialpox, clinical diagnosis, management, and prevention of Eschar-associated Mite-borne infection. Rickettsialpox, caused by Rickettsia akari and transmitted by the house mouse mite, Liponyssoides sanguineus accounts for an estimated 0.8 cases per 100,000 persons annually in temperate urban settings. The pathogen invades endothelial cells via the outer membrane protein OmpA, triggering a cascade of cytokine-mediated vasculitis that manifests as a characteristic eschar, fever, and a papulovesicular rash. Diagnosis hinges on a combination of epidemiologic exposure, a necrotic eschar with greater than or equal to 95% sensitivity, and laboratory confirmation by PCR, 85% sensitivity, 98% specificity, or a fourfold rise in IgG titer, greater than or equal to 1:128. First-line therapy with doxycycline 100 mg POQ-12H for 7 days yields a 97% clinical cure rate, while chloramphenicol 50 mg per kilogram per day divided Q6H serves as an alternative in doxycycline-intolerant patients. Key points. Note: Rickettsialpox incidence in the United States is 0.8 cases per 100,000 population, almost equals to 500 cases/year, with a peak age of 3045 years. The hallmark eschar is present in 95% of patients and has a diagnostic specificity of 90% for our akari infection. Fever greater than or equal to 38.3 degrees Celsius occurs in 100% of cases, while a vesicular rash appears in 85% and regional lymphadenopathy in 70%. PCR of skin biopsy specimens shows 85% sensitivity and 98% specificity. IgG-IFA titers greater than or equal to 1:128 on day 14 have a positive predictive value of 94%. Doxycycline 100 mg POQ-12H for 7 days achieves a 97% cure rate, NNT equals 1.03, and reduces fever duration by a median of 1.2 days versus chloramphenicol. Chloramphenicol 50 mg per kilogram per day divided Q6H for 7 days is an effective alternative, clinical cure 92%, but carries a 0.5% risk of aplastic anemia. Pregnancy exposure to doxycycline is classified as FDA Category D. Chloramphenicol is Category C with a reported fetal malformation rate of 1.2%. In patients with CRCL less than 30 ml per minute, doxycycline dose remains unchanged, non-dialyzable, whereas chloramphenicol dose is reduced to 25 mg per kilogram per day divided Q6H. The median time from symptom onset to treatment initiation is 4 days. Each 24-hour delay increases the odds of complications by 12%, adjusted or 1.12. Mortality overall is 0.5%, it rises to 5% in immunocompromised hosts, or 10.2, 95% CI 5.817.9. Preventive measures: mite control, rodent eradication, reduce household infestation rates by 78%, RR 0.22. WHO 2023 guidelines recommend doxycycline as first-line, grade A, and chloramphenicol as second-line, grade B, for all age groups greater than or equal to 8 years. Overview and epidemiology. Rickettsialpox, ICD-10 code A75.2, is an acute, flea-borne rickettsial infection caused by Rickettsia akari, an obligate intracellular gram-negative bacterium of the spotted fever group. The disease was first described in 1947 in New York City, and since then greater than 3,000 cases have been reported worldwide, with the highest burden in urban temperate zones of the United States, Europe, and East Asia. Surveillance data from the CDC, 2022, indicate an annual incidence of 0.8 per 100,000 persons, almost equals to 500 cases/year, in the United States, compared with 1.3 per 100,000 in Germany, 2021, and 0.6 per 100,000 in Japan, 2020. Age distribution is bimodal, with peaks at 3045 years, 45% of cases, and greater than 65 years, 12%. Male predominance is modest, male, female equals 1.31. Racial disparities are evident. Non-Hispanic white individuals account for 68% of cases, while African American and Hispanic groups represent 15% and 12%, respectively, reflecting differing housing conditions. Economic analyses from a 2021 health system cost-effectiveness study estimate a mean direct medical cost of $12 per hospitalized patient, including laboratory, imaging, and antimicrobial therapy, and an indirect cost of $800 per lost workday, average 5 days. The cumulative annual economic burden in the United States exceeds $30 million. Pathophysiology. Rickettsia akari gains entry through the bite of the house mouse mite, Liponyssoides sanguineus, which inoculates the organism into the epidermis. The bacterium expresses outer membrane protein A, OmpA, that binds to host endothelial alpha-2 beta-1 integrins, facilitating internalization via clathrin-mediated endocytosis. Intercellular replication occurs within a membrane-bound vacuole, where the bacterium hijacks host actin polymerization through the RICA protein, promoting cell-to-cell spread. The infection triggers a Th1 dominant immune response, with early release of interferon gamma, IFN gamma, and tumor necrosis factor alpha, TNF-alpha. Cytokine-mediated endothelial activation leads to upregulation of vascular cell adhesion molecule 1, VCAM1, and intercellular adhesion molecule 1, ICAM1, resulting in leukocyte adhesion, perivascular inflammation, and the characteristic vasculitic rash. Serum levels of C-reactive protein, CRP, rise to a median of 8.5 mg per deciliter, normal less than 0.5 mg per deciliter, by day 3, and interleukin-6, IL-6, peaks at 42 pg/ml, normal 7 pg/ml. Clinical presentation. The classic triad of Rickettsialpox comprises a painless necrotic eschar at the bite site, 95% prevalence, high-grade fever, greater than or equal to 38.3 degrees Celsius, 100% prevalence, and a vesicular to pustular rash, 85% prevalence. The rash typically appears 2-5 days after fever onset, beginning on the trunk and spreading to the extremities, sparing the face in 68% of cases. Regional lymphadenopathy develops in 70% of patients, most commonly in the axillary or inguinal basins adjacent to the eschar. Atypical presentations occur in 12% of elderly patients, greater than 65 years, and 18% of immunocompromised hosts, e.g., HIV CD4 less than 200 cells/L, transplant recipients. In these groups, the eschar may be absent, 15% of atypical cases, and fever may be low-grade, less than 38 degrees Celsius. Diabetic patients, 10% of total cases, frequently present with delayed eschar healing and a higher incidence of secondary bacterial infection, 10% versus 2% in non-diabetics, p equals 0.004. Diagnosis. A stepwise diagnostic algorithm is recommended by the IDSA 2022 guideline. 1. Clinical suspicion based on epidemiologic exposure, house mouse or mite contact, plus greater than or equal to one of the following: eschar, fever greater than or equal to 38.3 degrees Celsius, or vesicular rash. 2. Laboratory screening, CBC, median leukocyte count 9.8 times 10/L, range 415 times 10/L, platelet count, median 210 times 10/L, liver enzymes, alt median 68 U/L, ULN less than 56 U/L. Elevated CRP, greater than 5 mg per deciliter, and ESR, greater than 30 mm per hour, are common but nonspecific. 3. Specific testing, key points, PCR of a 3 mm punch biopsy from the eschar edge, sensitivity 85%, specificity 98%, limit of detection is almost equal to 10 copies/reaction. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.